So, good evening, everyone, and once again, a warm welcome to all our viewers to our channel, the Vitreous Table. And we have a new set of panelists for you who are going to teach you, learn from you, entertain you even more than last time what we had. I'm going to miss my friends, but some of them are here. But we have a nice, engaging panel. For today's panel, we have Dr. Shishir Varghese, who is the director uh, and a VR consultant. And I think he has won multiple awards for his surgical videos in APAO, APVRS, and across the globe. So he is going to show us some more and wonderful videos today from his library. Second person today is Dr. Mohit Dogra. I don't think he needs an explanation or what we need to say. He is a wonderful VR surgeon and UADS champion, and he's an associate professor at the PGI Chandigarh Institute in PGI Institute in Chandigarh. And we have our very own Dr. Avnish Upadhyay, who is a consultant, senior VR consultant at IQ Hospital in Delhi. So without much ado, apart from this, guys, we are going to bring in two more of our young vitreoretinal specialists, Dr. Parth Dave and Dr. Abhishek Upadhyay. So Dr. Parth Dave is currently a VR consultant at Baroda, and Dr. Abhishek Upadhyay, Abhishek, I'm really sorry. I think you're in Delhi right now, isn't it? You can unmute yourself.
Yes.
Right?
Good
Yes.
one, good one.
Yes, so
Very nice.
Abhishek Upadhyay is a young upcoming VR surgeon with wonderful skills, which we are going to see his videos as well today, and he's based from Gurgaon. So let's dive into our topic. This is a continuation of our macular hole trilogy, which is second episode today, and this episode is on conventional ILM peeling. So the first question that we are going to start with is to Dr. Shishir Varghese. Uh, in this is January 2026, about to end now. So in January 2026, Dr. Shishir, what are your indications for a conventional ILM peeling? And how do we select a case for a conventional peel? Can you elaborate for our listeners and our viewers?
Yeah, thank you, Dr. Bhavik, for the introduction and the question too. So I'll just share my screen. It's in the form of a presentation. Yeah, so thank you again for this opportunity. So we are in the webisode 4. So the question was, when do I consider a conventional peel? Now, for me, my personal cutoff is around, for us, it's a small macular hole around, stage 2 hole, less than 250 microns in size. Something like this would be where I'll be prefer to do a conventional peel, where I'm pretty sure that that conventional peel is gonna help me close the hole by removing that tangential kind of attraction. So this kind of hole, I would prefer doing a conventional peel. So if you actually look at the comparison between a conventional peel and the foveal sparing peel, most of the studies say that for small to moderate size holes, you can actually prefer a conventional peel because the visual acuity between both the groups remain the same, and also the fact that the sensitivity is much better when you are doing a conventional peel. So this is one of the studies which had around 25 eyes, randomized control trial, and it showed that the conventional peel had a better macular sensitivity as compared to the a flap. And if also they've given an example of how the conventional peel closure is like more of like an anatomical closure where you have the U closure as compared to a V closure with the ILM flap technique. So their limit was around less than 400 microns of the was the hole size for a conventional peel. Now one of the largest RCT is taking 2990 eyes where they did 119, sorry, 119 with conventional, with ILM flap and 2,800 with the conventional peel. They said that for anatomical success rates, the flap technique is better. But when you look at the visual acuity in the holes which have closed, there the conventional peel as well as the flap have similar visual acuity. So they say that for small to medium size holes, that's around less than again 400 microns, a conventional technique is enough for these kind of holes. So there, but for me, my personal cutoff would be around 250 microns because I'm looking more of a Mine is more of a private practice, and I need the hole to close and I'll be absolutely sure. So that I will do a conventional technique only if the hole size is around 250 microns. Now, these are the two other holes, large holes of more than 250, more than 400. These type of holes, I will definitely do the ILM flap technique for such type of holes. And then again, your question, one of the questions was, where would you do not peel an internal limiting membrane? And probably something like this, where you have a little bit of a, the anterior posterior vitromacular traction component, like an impending macular hole. In such a patient, I will just relieve the traction and leave it, and I would not do a, ILM peel, because just a vitrectomy here would help in closing the macular hole. Yeah, over to you, Dr. Bhavik,
Yeah,
to
I
stop
think
the
you,
sharing.
you brought in wonderful points, Shishir, in terms of less than 400 microns. But and you showed that visual acuity is better in just a conventional peel versus a flap in certain less than 400 to around 600 micron holes. But an important point you brought in here, this is what we read, okay, and this is what we follow in the ideal world scenario. You brought in a very important point about in a private practice where the pressure is there that the hole should be closed in the first sitting. So I want to bring in Dr. Mohit here, since you are working in an institute. Dr. Mohit, what are your indications apart from what Shishir mentioned for a conventional ILM peel?
Yeah. Well, my take on this is actually considerably different, and
Yeah,
it's
I want to
honestly
know
based
your
on
thoughts.
three things, right?
Yeah,
So if you were to look at, I think 400 microns and below, I think there is hardly any doubt that conventional works like a charm on two counts. And there is considerable data since, the landmark work in the late early 1990s about, removing getting the AP traction out and getting the ILM out. So 400 microns and less conventional peel works like a charm for anatomic and functional to the tune of 95% or better. For every 50 micron increase in size in minimum linear diameter from then on, so 450, 500, 550, 600, there is almost a linear decrease in the percentage of eyes that will close with a conventional peel. And for me, my cutoff is between about 525 to 550 microns. And why is that? Because the single surgery anatomic success rate of conventional ILM peel for idiopathic macular holes of 550 microns and below is to the tune of 82 to 87% in various trials. Now, and all holes that close with this technique in the first event will show more than 2 lines of improvement, given if they are idiopathic holes. So for me, the cutoff is 525/550, and anything more than that, I will go to a flap. I might even go on to 600 microns. Rarely, if the disc is zero point 0.7 or more cupped, and then I want to try and minimize the amount of ILM that I'm peeling, and I don't want to be doing stuff like that. So I will do a modification of an ILM peel, which is that I'll do a keyhole type in which I'll spare the papilla-macular bundle of I'll leave the ILM intact there, peel all around the hole in general otherwise. So 2 disc diameter around the hole, but leave the papilla-macular bundle intact, to try and ensure that I don't call retinal ganglion cell loss, which is more than what is needed, and also spend more time than I would normally in doing fluid air exchange, and then even close those eyes with that. But anything more than 600, definitely flap. Anything less than 550, definitely convention. Between 550 600 is where I generally tend to switch.
yeah. I think a very interesting point, what that you brought in about keyhole type of macular hole peeling. We'll come to it when you talk about safe peeling and how to avoid complications. So we move on now to one of our young vitreoretinal surgeon, Dr. Parth Dave. He's going to share us his video on conventional ILM peeling. Parth, if you can share your screen and give us your inputs that why did you think to start from that location and
Yeah, sure.
yeah, why do you decide to do a conventional peel? Can you share your presentation?
Yes, yes.
Any problems?
Is my screen visible? It is taking 1 minute, but it's not sharing.
Okay, I'll do one thing is I have your video. I'll share the video. Parth, are you able to share your screen?
No, I'm not able to share my screen.
Okay, wait a minute.
Just 1 minute. It came. I'll try once. Is it visible?
Yes.
And the video is playing, right?
No, I think there is a lag because of the poor network. You can't see your video. Okay, no.
Is it coming now?
Yes. Can you play it?
Okay, so yeah.
But there's a lag. 1 second.
Is it going on?
There's a lag. I think because of network
Okay,
bandwidth.
so I'll
You
just
can
stop sharing. You
yeah,
can take from your
unshare. I'll share it from my side.
yeah.
So can you all see my screen now?
Yes. So it was a case of a 45-year-old male with moderate sized macular hole of minimal base diameter of 318 microns. So it was a cataract of NS1 grade. So I went ahead with the direct vitrectomy. And if required, we can do a combined vitrectomy as well. So media clarity is of utmost important in all macular surgery. So I started with anterior vitrectomy and then I switched to the posterior mode. Just this is me clearing anterior vitreous. So in all the macular surgeries or all the interface vitrectomy, I use IVTA because I feel the PVD induction is of utmost important in all this kind of surgery. And this is after PVD, after IVTA usage, I went ahead with the PVD induction. This is the V-string formation, and after PVD induction, I extended to the periphery and went ahead with the core vitrectomy. So you don't have to go ahead with the extreme base dissection in this kind of cases, just to clear off the media, and you can go ahead with the ILM peel. After the, you can just fast forward it. Yeah. So yeah, this is me injecting BBG dye. So after injecting BBG dye, I switch off the infusion cannula, and after 1 minute, I switch on the infusion cannula and I aspirate the remaining BBG. Then I switch to the higher magnification, and this is the sharp skin forceps. And I started with the pinch and peel technique. So I usually make multiple flaps and then switch to the another instrument, which is end grasping forceps, which is relatively atraumatic. So I feel the fracturing of the ILM or the initiation of the peel is much more uh, cleaner and easier with the shark skin forceps. So this is with the end gripping forceps, I am extending the peel. So just like capsular access, if you want to extend the peel should be as close to the retina or as flat to the retina as possible. Because if you extend it or if you pull it anteroposteriorly, it is going to be a very short peel. So if you keep it flat, you can control the peel and you can enlarge it to the area, whichever area you want. So in this peel, I think one superior area was little adherent. And yeah, I had to switch back again to the shark skin forceps to peel, and I had one hydrogenic touch at this point of time. So after my, yeah, at this point, yeah. And it's better to peel it up towards the fovea, and you don't have to peel across the fovea. And after that, you just see the base to whether any treatable lesion is there or not. And if required, if you want to do base in the phakic patient, you can always switch to the air, and you can use the pneumatic lift to do the base dissection with the uh, little bit of safety. So I do fluid air exchange, and I always wait for 1 or 2 minutes to go ahead and again aspirate the trickle fluid from the disc. But generally, in the normal cases, I do not aspirate or dry up the macula, or don't go ahead with the soft tip to dry up the macula. So I wanted to ask the opinion of panels as well, whether they dry the macula every time or not. So after that, I switch to 20% SF6 and I close the case.
I think first of all, thank you so much, Par, for coming here and sharing a video. Uh, it takes courage to present your own cases on a forum like this. So thanks for that. Uh, Panelists, any questions or any comments you want to make or answer his question? Dr. Avnish, start with you.
Yeah, excellent case, Dr. Path. And there were some nuances which you discussed about where you were actually initiating the peel. The one thing which I could notice was when you were going in again with the second time, when there was this adherent, or maybe you could say the left out ILM. So doing that pinch and peel at times is kind of tricky when you're like, you're giving that jerky sort of, onto the prongs of the ILM forceps. So that could actually secondarily cause a break. So those are, I have some videos where I can actually, I'll be showing it sometime. Where instead of going there, like the red flags in these sort of cases is basically you have to be very slow. I think the initial peel was also very decently made where you actually went in. Uh, I would say that if you could have been slightly further away from the fovea, at least like, at least one disc minimum is what I would do it, or maybe I prefer doing it at least 2 disc diameter away from it. And then you can go but excellent points. I think you have covered most of it. I think I may be retelling the points. So great surgery. One of the things which you were talking about was FX. I still wait. I think for the FX, I think we have a discussion later on.
I think we will wait for it.
Yeah.
Parth, what will happen now is the questions what you asked and your video will be discussed as you go further. But important point what you mentioned is about having the right setup, okay, and media clarity is important. Having the good depth and stereopsis is extremely important for such cases. Like some people even switch over to a macular lens for better stereopsis and all. So that brings me to the next question, and a very very important question for especially a beginner, a fellow, or who is just about to start surgeries. That how important is the visualization in such techniques, and what kind of setup and the ergonomics that they play a role, that is extremely important, for which I want to bring in Dr. Mohit Dogra. So Dr. Mohit, I want you to discuss about the focus, magnification, stereopsis. Illumination is something which we have already touched upon in the previous class, so we can reduce the discussion there about toxicity of the light and the dye that we already covered in the previous videos. Yes, Dr. Mohit.
No, absolutely, Dr. Bhavik. I think very integral and important points. And I think a big shout out to Dr. Parth. I think what you did initially when you began, your patient was phakic, albeit a very clear lens. But what you did before you put on the condensing non-contact recite lens was to do the interior cleanup, right? What you said, your surgery actually began right after the ports with you doing your retro lens work. I think that's important. What's also important is to try and do that without the condensing lens in place once the patient is phakic, because you could be experienced surgeon, you could be someone starting out. The more anterior that you go, especially with the lens in place, if you have the condensing lens in situ, your depth perception tends to decrease. So any retro iridal slash retro lenticular work that you want to do, you ideally want to do it under the operating microscope's light and not with the condensing lens in place. Secondly, my threshold for making these patients pseudophakic is very low. So ERMs and MAC holes are two surgeries I would actually look at. I won't say I'll go down the Japanese path where they will every vitrectomy the patient has to be made pseudophakic. But even if there is a minimal cortical cataract, I would either want to do a combined, or depending on what your preference is, pseudophakia with that. How that helps is you can also get the posterior capsule out during vitreous surgery. That aids in visualization. Also, before you start, I think, and this is basics, not just for macular surgery, but in general, when you start your OT day, if it's more than one case that you're doing, the way to focus, and you would have seen it, people in your fellowships, your bosses, your mentors doing it. You really want to go high up on the mag, almost as high as your microscope would allow you to. Try and focus and then defocus and come out. That is going. Most people tend not to do it. It's a theoretical point for most people, but I tell you, it's going to be, it's a fail safe. The other thing is, if you're presbyopic, might not be true for most people here. I'm not presbyopic as yet. I might be the oldest in the group. I think it's important to try and ensure that your the refractive reticule is set to whatever power that is. That will help you focus better. Also help getting your surgical videos better. And one last point that I would also like to say is, if the patient has had recent pseudophakia, when I say recent, and the cataract, let's say, was dense, NO3, NO4, or it was a little bit of a complicated cataract surgery, or maybe there was some edema, please don't be shy in getting the epithelium off. If you're facing any kind of an issue, if it's soon after cataract surgery, especially if it's the same sitting. So I would suggest, if it's NO3, NO4 plus, try and defer the cataract and the vitreous surgery. Your vitrectomy view will be better. If it's anything lesser, then combine it, and those will, I think, improve your viewing outcomes.
Yes, I think that's a very important point, especially for the stereopsis during the initiation of the peel and the peeling itself. When you have corneal edema, you don't get the depth perception is different at different points. So that hampers in your viewing ability and your ability to ensure that you do a safe peel, because it's not a flat surface. You have to understand the retina is not a flat surface. It's like a bowl. So you're not at the same level. You are at different points, at different levels. Like in your video path, you're going at different places. So
Yes.
that was actually, if you map it, it will be different levels, different height, right? So wonderful points. Abhishek, you want to add certain points to this in terms of surgical setup or visualization quickly in a minute or so? You are muted here.
So, in terms of surgical setup, I think I would use the macular lens for macular hole or an epiretinal membrane surgery. And the better clarity that you have in the initial phases, it is absolutely essential that, as Dr. Mohit was also telling, that you have an absolutely clear and a magnified view. And this will help you to even start the peel. The most important part of an ILM peeling is to just start the peel, and the rest will follow. So a good setup and a good in biome, whichever system that you're using, focusing, fine focus. And initially, when we start, we just start doing surgeries, but power focality is also important. So adjust the microscope, adjust the biome, and you'll have a very good clear view before starting the surgery.
Thanks, Abhishek. You're giving me pointers. So, Dr. Mohit, to answer your question, we are also getting there towards presbyopia, on our way, reaching there in some time. Right? Avnish will agree to it. Dr. Avnish, I can't see you.
Maybe you're getting presbyopic, Bhavik. I'm just saying.
Not yet. There's still time for that. So you mentioned, Abhishek, very good point about initiation of the peel is what is the most difficult part as a beginner. Once you know, okay, this ILM is on, is separated, and then you can start your peel. So that brings to my third question today. That is initiation strategy and choice of instrumentation. Parth showed us a shark
Yeah.
skin. We'll come to you, Parth.
Yeah.
Right. So I want to bring in Dr. Avnish Upadhyay here. Dr. Avnish, where do you prefer to initiate the peel? Is there a landmark? Is some say under the vessel, over the vessel, temporal, nasal? How do you take your first bite? Like what Parth showed us with the sharp skin, he took the first bite. And how do you decide what instrument to use?
So a lot of things, like first thing first, for me, my preferred instrument is ILM forceps, which is by Alcon or Grishaber, which we use. And the other instruments which were used or are used infrequently is the finesse loop, where you actually brush it over the surface of the retina, and you try to peel it off. The initial peel is done. And third is the Tano scraper, which was there, I think. I remember long back, Dr. Saranan sir was showing his videos, and he could actually, before the advent of ILM forceps, they had this Tano scraper sort of a thing where you could make that initial neck into the the ILM and that dent, and then he could initiate the peeling later on. So I'll just Bhavik, if you can allow me, I need to share my
Yeah, please
presentation.
go ahead. Yeah,
So can you see my
yeah,
screen?
we can see it. Yes, go ahead, please.
Yeah. So a couple of things which Dr. Abhishek also pointed out. See, this is one video. I think I need to do it full screen, right?
Yeah, just play it
Not there.
on the top play.
Yeah, I'll just do it. Yeah, thank you. So a
Sure.
couple of things which Dr. Abhishek was talking about is that you can see this first video where I'm going in terms of what Dr. Path was showing. When I normally initiate my peel in the like in supratemporal and infratemporal area of the retina, and preferably 1 to 2 disc diameter away. I don't go on the nasal side to avoid the papillomacular bundle and the RNFL is too thickened. Second thing which Dr. Abhishek was mentioned about is the clarity of the retina. So what you can see here, I went in straight, I adjusted my microscope and the biome, and then I'm trying to peel, but now you can see here, I'm not able to actually see it that clearly. I'm trying to zoom in, I'm trying to focus it, and then later on, if that thing is not coming off. So what you can see here, it is not that, I think here I was supposed to tell you this. So you can see it's not that clear. And later on, when you adjust your fine focus is where you can actually see the surface of the ILM. So what is important here is you should be able to appreciate the ILM surface, and that is where you can initiate your peel. So once that thing is done, you can do it. The second video is actually the conventional one, which you can actually see here. So what I do is I go near the blood vessel. I prefer going there, and that initial pinch is like my technique is to pinch it, release it, then grasp, and then to peel it. The peeling, initial peeling, which I tend to do here is not the radial ones. I prefer doing it a bit more, tangential one. And then once that thing is done, I tend to wait for a second or two so that, sorry, if I'm, yeah, sorry again. So here, if you can see, I just wait, I let the retina blanch, it becomes more whitened, and that is where I know where the plane of ILM would be. And my initiation would be, like circumferential or maybe, spiral, or what you call, it is as parallel to the surface of retina. If you tend to go a bit more radial or towards the centripetal force, you will, you'll have some trauma. If you're going, more anteriorly, the flaps would be smaller, and there's a very big chance where you can actually have a trauma to the. Now, this is another case where you can see what actually happens here is I initiate the peel, but then there is something which is happening and I'm not able to actually do the peeling. So initially I thought it was my hand which was not there. And you can see these sort of jerky movements, but you actually see the ILM forceps is not closing when it is going closer to the surface of retina. So initially it is pinching in, but once you can see here when it is not opening fully and not closing when it is on the surface of the retina. So this is also very important that the instrument should be doing well. So or else if you will have these sort of traumatic iatrogenic sort of instrumentation related problems. So these are the 3 pointers which I wanted to point out. So when you have these sort of things, this is what one needs to do it. So this is from my side, Dr. Bhavik.
Yeah,
So
thanks, Avnish. Yes. Parth, you had a comment, and I wanted to know that why the reason for initiating the peel with the say shark skin and all.
Yeah, so already Avnish sir has covered this, but generally I start my peel temporally in the initiation. Initiation should be done temporally, or you can start infratemporally in your early days, because if any iatrogenic touch or scotoma happens, the scotoma would be superior, and that part would be covered with the eyelid. And once you get an experience, you can start going near to the arcade vessel. So the surrounding that arcade vessel, the ILM is little bit lifted. So these areas are easier to start a peel. Also, you can look for the ILM folds. So if you are seeing ILM folds, that means the ILM is loose at that area, and you can start peel from whichever area has a ILM folds, and that would be much easier and safer way to start a peel. And I would like to show one. I'll share my screen.
I think Parth will come to it.
Yeah. Okay. Okay.
Okay, and to all our listeners and viewers, we have surprise as well. So at the end of this session, we'll be having an expert commentary by Dr. Rajanarayanan, where he'll be sharing his points about ILM peeling, especially for the beginners, and what pros and cons, what you have to do for such peels. So stay tuned towards the end of this meeting as well. We move on to Dr. Abhishek. Abhishek, please share your screen and show us your way of doing this conventional ILM peeling.
So, if it's possible, can you share the video?
Yes, I'll do that. Sure. Can you see my screen?
Yes, sir.
Yeah.
This was a 45-year-old female patient who with a macular hole, and there was no cataract, so I opted for just vitrectomy in this case. And the conventional steps we have skipped. So after BBG staining, I had planned, since this was just more than 400 microns, I had planned initially for a multiple flaps because that is the usual technique that I would opt for. I started from the inferonasal location since it was much more convenient for me to start the peel in that particular direction with my right hand. As you can see, I've made very long flaps, and the patient suddenly moved and the flaps got engaged in the ILM forceps. And because of that, all the flaps were lost. So according to my initial plan, I wanted to leave flaps over the macular hole because the patient was very unwilling to return. So I wanted something that would work 100%. I was trying to place the flap on the hole, but I was not able to. I tried with the infusion even off, but still, as soon as I would switch on the infusion, the flap would go away. So in the end, I thought that let me try something else. I still had superior ILM. So I initiated the peel normally and then put PFCL so as to stabilize the flap. And then under PFCL, I made a very long free flap and then positioned it over the macula. And then a fluid air exchange. And a very slow fluid air exchange was done because I wanted the flap to stay in its position. In the end, I used a SF6, and this was on post of day 10. The hole had already closed.
Great. So you gave us nice intro for the next class number 3 as well, which is supposed to be about flaps and AMG as well. So there's a reason why we asked you to present this video, not just because of the flap, but your technique of starting the iron peeling. Okay. So one interesting point you made here, it depends upon the eye also where you're going to start. Okay. So though conventionally people say it is temporal, superior, inferior temporal, but I want to tell the viewers that if you're a beginner, be comfortable in what is the best location for you in terms of the depth and the stereopsis, and you feel comfortable starting from that position. It can be inferior, it can be superior as well. Dr. Avnish, what do you have to say about it?
I would agree, but I would still prefer going
Yeah.
inferiorly. I think that is the way. And initially, I think doing it a bit more superiorly becomes a challenge. Maybe
True.
for a left eye, I would be more comfortable. I think conventionally also, since you are more inferior, I think doing a flap becomes like the initial pinch and peel, which we tend to do. That initiation should be in a way where, like we are a bit more skeptical if we are in the suprotemporal quadrant in either of the eyes. I think to move it in that stance becomes slightly difficult. So I would prefer, from my preference, would be infratemporal. I think we can ask the others for
Yes.
their
So
opinion as well.
this brings us to the next topic, interesting topic about safe peeling. What we're discussing right now is about safe peeling and intraoperative troubleshooting. That how you have to maneuver, like you used a PFCL, okay, because your flap was not able to, you're not able to place the flap. So it's such kind of troubleshooting that you have done. So I want to bring in Dr. Shishir again here, who is we are consultant Amita Eye Care. Shishir, what are your cues for staying in the correct plane and avoiding, say, micro bleeds? Okay, or retinal trauma, or what we discussed, that there's a retinal touch in the first video as well. So how do you deal with such scenarios? Yeah.
So, I mean, we already discussed about the fact about the lenses and all, but I also want to say, especially when you're in a setup where other doctors or other ophthalmologists are also operating on your microscope, should make sure that the eyepiece, first of all, is tuned to what your, visual, I mean, your refractive error or whatever it is. You should be in zero, first of all, because sometimes, the other doctors operate and my eyepiece is usually around minus 1.25 or 2. So I make sure first that is zero. Then second is using the macula lens. You should focus it yourself and make sure that you're absolutely you can see properly. Then the third, so these are the two things regarding the lens and also regarding the microscope. Then the third thing is regarding staining. So now usually the elderly macular holes, the PVD is already induced, but there are cases where where the PVD is not induced, and then you need to induce the PVD first, like how we saw in Dr. Abhishek's case, and then after that you need to stain. So in that, the trick there, what which can ensure a better staining as well as a faster reducing the surgical time, is you induce your PVD just till around the arcade, and then you go in with your BBG dye and stain, so that it stains and it concentrates only in the posterior pole. And then once that happens, then you complete your with the dye inside the eye, you complete the rest of the steps. You complete your PVD induction, you do finish off your the uh, base shaving after you induce the PVD, and the dye remains concentrated right at the posterior pole, and then slowly you can remove it. So this will ensure a proper staining, and that the staining is what is going to help you in getting a really good visualization of the ILM. So this can be impeded if there is ERM, in which case you need to peel and do a repeat staining. So staining properly just after inducing a PVD, where the bulk of the stain remains in the posterior pole, and second is repeat staining as and when required. So I'll just share a screen.
Yes, please. Yeah.
Yeah, so you also mentioned about intraoperative troubleshooting. So what we see are these hemorrhages, which we saw in almost all the videos which we saw. And the most common cause of these hemorrhages is the superficial capillary plexus, which tends to tear when you, peel the ILM, because the tearing
Trauma.
of the molar cell feet and then the traction gets transmitted. So that is the most common reason of the tear, and the most, why it happens is because if patient is diabetic, hypertension, even in high myopes, it can happen. And also if they are, it's also seen in those who are on aspirin and clopidogrel, even though we stopped that before surgery. So these are one of the most common reasons where those kind of hemorrhages tend to happen. And other reasons, pinching the retina, you go aggressively in, your instrument is not okay, you go and pinch, then the bleed can be much larger than what you see when you just peel the ILM, if you have multiple failed grasps, and then what Dr. Avnish mentioned, the jerking, if that happens. So most of these bleeds, especially if it's because of the peeling of the ILM, it's self-limiting, and only thing you need to do is raise the intraocular pressure. So this is one such video where you can see it's not stained very well, but still I'm able to see a little bit of the ILM. And you can see once I have peeled it across, you can see that it's bleeding. And then I'm initiating in another area, and that also has started bleeding. So I usually operate at around 25 to 30 millimeters of mercury. And in such a case, I'll ask her to raise the IOP to around 40 to 50 millimeters of mercury, which will contain the bleed. Now, since my visualization was reduced because of the poor staining, I restained it. And then you can see how well it's stained. And that's the end of the surgery, where the bleeds, tend to form a small clot, and it's contained under the fluid air exchange. Yeah. So I think that's about the.
Yeah, I think interesting points here in terms of minimizing the bleeding and how to stop it. Sorry, this was earlier covered, but I just want to bring it since I saw the BBG dye being injected as well. One has to be careful about a jet stream injury. Okay, so always inject outside. And I
Yes.
would suggest that rather than directing at the fovea, even I think in Abhishek's case or Parth's case, we noticed that one can also direct the dye on the light pipe or either in the superior or inferior part of the nasal retina. That will prevent a kind of jet stream injury. So I'm sure here all the surgeons are experienced with their use of BBG, but especially for a beginner, inject outside. There should not be any air, and once you go in and try to inject on a safer part of the retina. Great.
I'll
So
just finish
yeah,
the
please.
just one more
Sorry,
slide I'll
sorry.
just mention. So
Yeah,
since you yeah, sorry. So since you mentioned regarding the what can arise from a complications of an
yeah,
ILM peel, I was just reading a little bit of a literature report. So one I already mentioned, the the retinal and the subretinal hemorrhages have been described when you peel the ILM. Sometimes you can have macular edema. Post-operatively, you can see after a macular hole surgery. Scotomas already mentioned, you can have paracentral scotomas which appear as ERG changes too. So another thing is foveal displacement towards the optic disc is very rare, but it has been described when you peel ILM for macular holes. And another couple of case reports are there where even have had CNV formation and RAP, which are extremely rare after ILM peeling for macular hole. And the most common one which we encounter is the Donfell or the dissociated optic nerve fiber layer. So that usually again happens because of the trauma to the footplate of the Muller cell, especially in the nasal region, and that's why they appear in this arcuate shape pattern. And it's seen in around 50% of the patients within 3 months who have undergone an ILM peeling for macular hole. So this is one of the study which showed that it's basically the acute inner retinal layer thickness, which occurs post peel, and it's associated more with macular hole surgery. But there's still actually a doubt as to why exactly this kind of a thing happens, this Donfell. And it doesn't necessitate to a reduction in visual acuity or anything like that, but it's just like a feature seen on the OCT.
yeah.
So I just wanted to highlight just these parts, especially when it's the complications of the peel.
Yes, yes, food for thought for a lot of our viewers and listeners as well. Thank you, Dr. Shishir. Uh, so this brings me to yet another question of our session, that is fluid exchange. Uh, I think Abhishek mentioned in his video that he tried to do a very slow FX to ensure that the flap did not dislodge from the hole, right? So the point is about a slow fluid exchange. Some people also go in and do a bone dry in terms of like completely dry. There should not be any fluid, neither the disc nor the hole as well. Some people even try to put the flute over the hole to ensure its closure. So that is where I want to bring in Dr. Amish and Dr. Mohit here for our second last question. It's about what is your preferred way of doing fluid exchange? We'll start with Dr. Mohit first. Your tips in doing a good, efficient fluid air exchange.
Yeah, I think for conventional Mac hole surgery, when you do a conventional peel, I don't think one needs to go down on the speed, so to say, of doing a fluid exchange, because there's no flap or there is nothing that you are fearing dislodgement for. So you do as you would do normally. Let's say if you're as you would do in, let's say, a retinal detachment surgery, like 35 millimeter of mercury, whatever's your go-to pressure, you stick to that. You begin with an active extrusion because you don't want to spend too much time, because time is of the essence. I think, if one needs to be efficient in surgery, go all the way down to the optic disc. And what I generally tend to do then is, I always check my three ports in all surgeries, but macular surgeries particularly. So I will do that. I will, from my side, just do the whole shebang on one go, go up to the disc, and at that point in time, try and remove as much as I can, and then go and depress and see my three ports, my two active ports and the infusion, and to see whether there is any break or anything that I need to do, and then come back. What that ensures is two things. Whatever, that there will be some seepage of peripheral fluid posteriorly. I'll also kind of expedite that a bit by doing that depression in the periphery, which is something that I would have anyways done. And then my second bite at the cherry to try and ensure that it's a more complete fluid air exchange is I take a passive soft tip, of old school passive extrusion, and then I go at the optic disc and ensure whatever residual fluid is there after my three-port depression that I did. I suck that out and then I come out. I do not go to the macular hole edge or the macular hole center, not for conventional peels, not for idiopathic holes. I may do it for and that's not the topic for this. The only exception to that is myopic staphylomatous eyes with posterior pole retinal detachments, in which I've done what I have done, and prior to making a flap, I want to try and remove all the fluid because I just don't trust the RPE in those kind of diseased eyes. But not going to the hole and trying to do fluid air exchange in these conventional peel eyes.
Okay, Avnish,
I think most of the points Dr. Mohit has covered, but still there are some things which I would want to discuss, which people should be aware about. I think I think I can. Yeah, if my slides are visible. So I think Dr. Mohit has actually talked about how do you actually do an FAX where you actually go in directly, and that initial active suction is required, and then once you complete it, you do it bone down. This is what I prefer. So how do you see whether it is dry or not? Is the meniscus of the fluid which actually disappears. So you can see that with repeated this thing, it will disappear. The second one is basically where I'm showing where you go in for I prefer waiting for a minute or two, so letting the peripheral fluid come down. And at times I can use this sort of a perimacular areas where you can use it as a wick, and those areas, if there is any fluid, that can be aspirated. I would absolutely agree with Dr. Mohit about the foveal where people aspirate over the fovea, because I have burned my fingers. And something which I actually want to talk about is you can see this first photograph on the left side. You can see the size of the fluid which is there. So you can see the fluid which is there, which was there 4 years ago, and now this is the third year more. The fluid which you can see, it is more smaller, it is more rigid. This is big because now we are actually having the tracker, the trocar, and the cannulas. The cannulas are mostly valved. So because of this valving, this the size of the flute has gone down. So I prefer what Dr. Mohit was talking about, and this is where I actually tend to do my in especially in conventional techniques. I try to do it. I couldn't get a video where I'm actually using a cutter, but I prefer using a cutter. I think Dr. Sisher would agree. We have had talks about this because it saves your time. It saves unnecessary using, the flute. And if you are especially using the ones where you will talk about the flaps, this is where it can help, and you can actually maneuver it. The cutter size
out
should
of it.
be away from this thing. So these are some things which I would wanted to re-emphasize. And this is one of the videos where I used to do it 4 years ago, where you actually went in over the over the macular hole and used to do. So these actually cause incarceration of the retinal tissues within the the flute sometimes, and this causes atrophy and the macular holes don't close. Sometimes it can happen that because of the active suction, there is this vacuum which kind of gets developed, and that can cause air bubble behind the edge of the macular holes, and that can cause failure of holes. Then one more thing which I wanted to reemphasize was the edge of the hole, what Dr. Mohit was talking about. Sometimes when you're doing very active suction, the amount of fluid which is coming from the base, that can rehydrate the edges, and that can also cause a failure of holes. So I would strongly recommend need not do very active suctioning, use a flute or use a passive extrusion. And this will and do it very slowly. That initial active suction is can be done, but once you are at the surface where there is very minimal fluid, please go ahead and do a passive suction, and please don't do it over the hole. Yeah.
Okay, so interesting.
Bhavik, I just wanted
Yeah,
to
yeah,
make one
please.
small point, and this was just in continuation with, I think, Dr. Parth's video. And also just to complete the fluid air exchange, if you had a small or a not so small bleeder when you were doing the ILM peel and it's now plugged, which in most cases it does, when you're doing fluid air exchange, please do not try to remove it with your active or passive extrusion at that point in time. You're there to get the fluid out and replace the fluid with air. The plug, the body has done an excellent job of tamponading whatever micro or macro bleeder you had. Please do not dislodge it with compromised view at the end of your fluid exchange. Let it be. It's not going to do anything. So please don't, let, as they say, let the sleeping dogs lie. They're not doing anything.
Yeah. Great. Wonderful points, Dr. Mohit, as excited as ever. So, Dr. Avnish, you mentioned about failure of macular hole closure. Okay, especially if there is hydration on the whole edge, which happens. So, this question now to all three panelists here. Okay, what are the common reasons that you have encountered where a conventional ILM peeling has failed? It can be related to the size, technique, maybe two points from each of you, or 1 point before we go on to the final expert committee by Dr. Raja. Shishir, will start with you. Shishir, Avnish, and Dr. Mohit.
Yeah, so like I said, so initially what I was taught is for that, for every hole, just do the conventional first. If it fails, you do the flap, or free flap or ILM flap, this thing. But then now, after coming to the practice, I've decided, I mean, initially also for very small holes, I used to do the conventional technique. But now for almost all the holes above 250 microns, I've shifted to this thing, inverted ILM flap techniques. And very, very rarely I'll do the conventional technique, because it gives me good, almost 99% anatomical success rates. So the failure, if you have asked, I mean, especially for the conventional technique, some of these holes I really don't know. It's a little bit unpredictable. It depends on a lot of factors, actually, from the size of the hole to the positioning of the patient to the the amount of the gas which is there in the eye, whether it's like post-op day one, sometimes the gas will only be half filled, so the dilution error of the gas, and some of these patients require tamponade beyond 6 weeks, beyond the, usually we all put SF6, but some of them, they may require a tamponade beyond the 2 weeks, or 3 weeks, or sometimes even 6 weeks for that hole to close. So seeing all these different kind of factors is why I have switched to the ILM flap technique, especially in my practice. So I cannot really pinpoint and say that this is the reason why this kind of a hole failed, because it's multifactorial thing. And in conventional technique, it's very difficult to convince these old patients to do their head face down positioning, especially at night. So the flap, in the flap technique, what I tell these patients is to just lie on the side of the opposite side of the eye, where, because it's a temporal flap, and my theory is that the flap will gravitate down, because of the gravity will help in keeping the flap towards the side of the hole. So I really don't advise these patients to do a prone positioning at night, especially if I have done a
Flap.
inverted ILM temporal ILM flap. So yeah, it doesn't have any study or any basis behind, but it's just my logical reasoning that
Correct.
the positioning per se, when you have done a flap, is much less strenuous as compared to when you do a conventional technique.
Parth and Abhishek, I come back to you now in terms of understanding that what could be the reasons in your cases where you have encountered failure of a macular hole closure. Okay, so we all are surgeons, we are all going to have this kind of scenarios. So, Parth, what could be the reason and what are your points here?
So one could be the amount of peel what you have done, and one if you are choosing the wrong case. So if you are choosing conventional peel for the traumatic or chronic macular hole, or even the myopic macular hole, that could lead to a non-closure of the hole. But in a well, normal macular hole where you see the height of the macular hole is good, and it looks like a fresh macular hole. These are the cases where the conventional peel would be much more helpful, while in myopic and all, you might need another types of peel.
Abhishek, thanks, Parth. Abhishek.
In my hands, I think in the initial days, I used to make flaps from wherever it was possible. I did not used to think behind the reason that we should make a temporal flap or we should make a. So one of the few cases, I think I made an inferior flap. It was much more easier for me to put the inferior flap over the macula, and that hole did not close. So in the initial days, I realized that, I should not be making inferior flap because it will again go down,
Yeah,
as Dr.
gravity, what
Shishir was
Shishir
saying.
mentioned, right? Yeah.
So those flaps, those holes did not close. Also, I feel inadequate staining plays a major role. So if in my cases, if I'm not able to see properly, I would re-stain. Re-stain and get a very good view. Plus, in cases in which the ILM is very sticky and it comes in piecemeals and not as a complete flap or a loop, just comes in bits and pieces, and those are very tricky cases. And those holes also, I'm talking only about idiopathic macular holes, those holes close very difficult.
Okay. Great points. Any other points, Dr. Avnish and Dr. Mohit, apart
Just
from?
wanted to emphasize about the edge of the holes also. Sometimes when you're peeling off across, that is what Dr. Path was talking about. You have to be, you have to, when you're going across the macular hole, the edge of the hole should not be, it should not be a radial sort of a peel. It should always be tangential. Because sometimes when you peel it radially, you can yank the edge, and that can cause neurosensitive attachments and rips there, and it can cause bleeds, and that could cause. So when you are actually approaching the edge of the hole, you should be very gentle, and you should try to do it more tangentially rather than going across. So that is what my point. That could be one of the reasons where you can have a macular hole which persists. And the other things which I talked about was rehydration, which could happen because of lactic suction over the hole. Yeah.
Just two very small points not related to, I think they've covered all of it. I think the smaller the hole, the less you do. I mean, just because we can try and do everything under the sun doesn't mean we need to do for small holes. And I think I beg to differ with Abhishek. I think your case, Abhishek, was a spectacular case to just close with the conventional flap. In fact, with the conventional peel, because your case, in fact, the hyaloid was attached to one of the edges. I mean, it was almost like one of those, lid wale dustbins, in which you get that off and it'll close on its own. I would strongly urge you to try and do just a conventional peel in those, and those would close. So I think, like with the Reg RD, if the fresher the RD, the more non PVR the RD, the shorter and the minimally invasive your surgery needs to be. Similarly, I think with the Mac hole, fresh, early onset, smaller, hyaloid still attached to one end. Uh, Conventional works like a charm. And if it's not happening, then either there was vitreocytosis that one chose to neglect, or there was like in one of the cases of Avnish that he showed, there was patchy ILM stain, there was patchy staining, so there was a component of ELM ILM there, so we just went ahead and peeled the ILM, and maybe the ILM was left behind. If you're confident the ILM is off, it would be spectacularly uncommon to have something like what Dr. Abhishek showed, that hole to not close with conventional peel, gas, and face down.
Yes. Dr. Dogra, it takes some gray hair for such kind of wisdom to come in. So it takes time.
Well, lots there then, man.
Great, great. Wonderful session, guys. Thank you, Dr. Par, Dr. Abhishek, and our esteemed panelists, Mohit, Avnish, and Shishir. So now we move on to our next session, that is an expert commentary by Dr. Raj Narayanan. I would like to thank him to send us his video and his views on conventional iron peeling. So I'm going to play it now for all our viewers, listeners.
Hi everyone, I'm Raja Narayanan, faculty at Pharma Institute, University of Rochester, and I would like to explain the nuances of ILM peeling. Learning the correct technique would help you master ILM peeling. So let's get started. So ILM peeling, which is also sometimes called maculorhexis, is very similar to capsulorhexis. The only difference is that the capsule is not a sensitive structure or the underlying cortex, whereas when you peel the ILM, the underlying retina is a very delicate structure and you want to be very sure about the plane. But the steps of doing a capsulorhexis and maculorhexis are very similar. So let's see on the left-hand side the video. First step is to break the capsule and then extend the nick and then fold the anterior capsule. So these are the three important breakdown steps whenever you want to peel the ILM, that is to break the ILM, extend the break, and fold the ILM to peel. So let's see how we can do this with ILM. It's easy to do with the capsule, anterior capsule, because you can puncture, you can go deep into the cortex with your cystidome, but while breaking the ILM, you don't have much depth that you can work with. So this is how you first break the ILM, that is pinch and peel. You open the forceps very narrow. The opening should be 100 microns or less. So when you get the forceps and you enter the eye and you open, it's about 0.4 or 0.3 millimeters width of the opening, but you should close it or narrow it down when you hold the ILM and then pinch and release and then extend the ILM break and then you make the fold of the ILM. It's easier to learn ILM peeling by just changing the terminology to ILM folding. So you know where to pull the tissue or in which direction to pull the ILM. Because sometimes the fellows can have a confusion as to which direction they should be pulling. So just simply fold the ILM once you break the ILM and it will get peeled. This video shows a fellow trying to peel the ILM very rapidly. So you should never attempt to peel the ILM the first attempt. As I said, the first step is to break the ILM. The second step is to extend the break. And the third step is to fold the ILM. Because if you're not holding the correct plane, if you're holding more tissue of retina, you are likely to cause retinal damage. ILM peeling is a slow procedure, like I call it slow cycling. It's more difficult to cycle slowly, but you are less likely to fall if you master it. Now, in this video, you can see that the plane is not being looked at. As soon as the fellow is grasping the retina, is trying to peel it off. So the first step is to just hold it gently, make sure what you are holding, and then attempt to just fold it in a horizontal plane. Don't try to lift the ILM off the retina. You should go almost parallel to the surface of the retina to peel it. This is a video showing the ILM peeling steps. So the first step is pinch and then release. You should not attempt to peel. So these are sideways movements, making sure that I'm seeing that the retina the entire retina is not mobile. I'm holding something. But as soon as I have seen a gap in the ILM, that there is a broken ILM, I now extend it like a capsulorhexis. Again, just see how much retina is visible during this step. I can hardly see the disc in this step. That should be the magnification. Just about the disc and arcade should be visible. It's a high magnification procedure. You should not be seeing the equator or aura to aura. When you're doing regular vitrectomy, you can use a wide angle lens. But for macular surgery, you need a high magnification. You can use the different lenses available, but I would say contact lenses are the best, both for beginners or even for advanced surgeons. Any day, a contact lens is a better lens for visualization. And also, I want to you to note that I'm seeing through the gap in the forceps. You see the two arms of the forceps, they don't touch each other except at the tip. So this is an intentional design in ILM forceps because you want to see through the gap between the arms of the forceps to make sure you are holding just the ILM. But again, this video was showing the nice stain, the high magnification, and also the 3 steps: break, extend the break, and then fold the ILM. The next slide. And this video shows the wide angle lens for vitrectomy PVD induction. And once the PVD is induced, you have a good staining and then switch over to a contact lens if required. But then the steps of breaking the ILM, extending, and then folding the ILM. Always attempt to just fold the ILM. That's the best way to peel the ILM. And you see this is a sub-ILM hemorrhage here. Easily it came otherwise because the ILM was detached a little bit because of the blood post trauma. And again, it's a high magnification. I'm not seeing the disc or the equator during the procedure. So just to conclude, ILM peeling is considered the final frontier in fellowship, but if the steps are not learned the correct way, ILM peeling would be a struggle. So I hope you have learned some steps of how to do a safe and efficient ILM peel in simple cases. And please feel free to email me if you have any questions. Thank you very much.
Yes, I think that was an excellent video by Dr. Rajan, and we thank him for that, for giving us the knowledge. So with this, we come to an end for our second topic or second session on macular hole, that is conventional ILM peel. We meet again within a month's time for our third session, that is an advanced ILM peeling, where we're talking in detail about flaps and the different kinds of amniotic membrane grafts, sclera that can be used for such kind of difficult or larger macular holes. So until that, thank you so much for joining, and we meet again. Thank you. Thank you to all the panelists and Parth and Abhishek. Thank you for staying with us.
Thank you.
Thank you.
Thank you, everyone. Great cases. Thanks, Bhavik. Great work.
Thank you, everyone. Thank you.
Bye-bye.
Just a suggestion that if you have any feedbacks, please mail us to the vitroustable@gmail. And we have our Instagram account as well, where you can actually send us your feedbacks as to did you like the commentary, or if you want any suggestions where we can incorporate, and what sort of topics you would want to discuss. And thank you, Dr. Bhavik. Excellent moderation. I think we covered the best of the possible nuances in macular hole surgeries. Thank you.
Thank you all. Good night. Okay. Good night, guys.
Thank you, guys. Good night.
Thanks, guys.
Thank you.